Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by
Then there was a
anyone.
question on what is trial forceps. What is trial forceps? An attempt to deliver a baby using obstetric forceps under controlled conditions. Okay. And trial means that you're trying the forceps. That means once if it slips or it fails, you try once more and then you abandon it. Okay. And of course, you can write down the criteria for a trial. The cervix should be fully dilated, head should be engaged, it should be below station 0, and the person who's performing the forceps should be experienced in a fully equipped labor room. OT should be informed. Okay, anesthetist should be on call, because every time if you have a failed forceps, the only way to handle this patient is basically through cesarean section. Yes, dual setup for OT. OT should be informed. As anesthetist should be, at bay. These people should be right there. Some people call the anesthetist in the labor room. Just in case it fails, I want you to give her the spinal anesthesia and I'm not going to wait anymore. Because just imagine where you're putting the forceps. You're putting forceps at +1 station or at least above 0 station. Just imagine how will you do a cesarean section in this patient. Very dangerous. All right. Now, causes and management of a failed forceps. Can you tell me the causes of failed forceps? Maybe the person who's performing the forceps is inept, not experienced, number one. Second, there could be a part of asynclitism. The baby is not exactly, the head might not be rotated properly. Maybe you're applying high forceps. Maybe there is some amount of cephalopelvic disproportion. Maybe the head is not completely rotated. Okay, so these are a few things. Improper application of forceps. You've not applied it properly. You're not experienced enough. Incorrect diagnosis of fetal head. The most important thing. I consider myself very good in applying forceps. I have a very stellar record when it comes to forceps application, but I also had a failed forceps, and not once. I did it 2 times and it failed again and again. And I was so upset with that thing. But the answer was that there was an incorrect diagnosis of the fetal head position by me. Okay. So the head was not rotated properly and I was missing it. What happens is when you have a lot of caput formed, you can't really find out the sutures, You try anyways. Let me just try. Just in case it comes, it's good. If it doesn't come out, then that means I was wrong. You go the other way around. So because of caput and molding, usually the sutures are not able to be appreciated properly. But you can still make out the anterior and posterior fontanelle, isn't it? Yeah. Very good, guys. Very good. So what do you do when that fails? My immediate action will be to call an anesthetist, give spinal anesthesia, and let's go ahead with a cesarean section. So one thing you can do is immediately abort the forceps delivery. The first sign of failure. Why? Because you do not want to give any injury to the mother or the fetus. Number one, most important. Number two, you reassess whether it was wrong application, whether it was wrong judgment of the fetal head, whether it was a wrong judgment of the fetal station, whether it was a wrong judgment of the rotation of the fetal head. What was wrong in that? You can reapply only with, standby of the OT staff and the anesthetist. Because this time, if it fails, you're abandoning it for good. One more choice is that you can go in for a vacuum delivery, but usually when you're doing a forceps delivery, you do not abandon it for a vacuum delivery mostly. The answer will be a cesarean section. Okay? That's it. That's pretty much it. And how much was this answer for? Okay, 4 marks. So 2 marks you give the reasons why it failed, and 2 marks you'll give what do we do if it fails. Okay, good. Okay, one more question. How will you diagnose and how will you manage Kifel hematoma in a neonate following instrumental delivery? My answer was that I am not a neonatologist. I'm not the expert here. Why are you even asking me this question? But diagnosing is very important. Managing is also important. When you hear me, you'll say, oh, there's actually nothing which we have to do. So might as well manage also. Yeah. So I will not let you rack your brains in this, guys, because this is something Kifel hematoma. This question has been asked, but not in this form. See, I keep telling you this thing, guys. Whenever this kind of questions are asked, usually capillary hematoma, how it was asked, the difference between caput and capillary hematoma. This has been asked before. multiple times in different methods. Sometimes Kefil hematoma and this caput succedaneum has been asked. Sometimes Chignon and Kefil hematoma has been asked. Sometimes the differentiation between the two has been asked. All these, but this question: how will you diagnose? How will you manage Kefil hematoma? I don't think this question has been asked in this form before. So how will you manage? How will you diagnose it? See, it will be a progressive swelling. It will be a progressing swelling. Appears usually hours after the birth. And it happens in 24 to 48 hours. You have a soft, fluctuant swelling, and that is confined to one of the cranial bones, very characteristic. It does not cross the suture lines. And the skin overlying the hematoma appears normal. There is no discoloration, there's no bruising, the skin is fine, but there's a very fluctuant, boggy kind of a swelling over here. It happens in one of the, and does not cross the suture lines. It can occur with caput succedaneum, okay, but it usually is associated with some skull fractures. Okay, there is a huge risk of jaundice because hemolysis starts happening in this hematoma. So how will you confirm the diagnosis? With the help of ultrasound, with the help of X-rays, with the help of associating with the neonatologist. Okay, they are the experts. They'll be able to help you out and tell you. Always mention this term. Okay, neonatology team. You have to monitor the level of bilirubin. You have to monitor the level of hemoglobin. If the hemoglobin is dropping and the bilirubin is increasing, that means the hematoma is expanding. You have to, take immediate actions. Otherwise, it can happen. It can be very well managed with observation alone. Most cases resolve spontaneously over 2 to 6 weeks as the blood is reabsorbed. And you could just have to monitor for changes in size, skin integrity, signs of infection, signs of decreased hemoglobin, increased bilirubin, so on and so forth. Okay. Phototherapy can be given if the bilirubin level is increasing, because bilirubin to a certain extent is fine. After that, it's not good. So you can't keep waiting forever. Anemia might require blood transfusion because hemoglobin sometimes can go significantly low. Of course, you have to be on a lookout for any infections. You have to have a proper monitoring with close liaison with the neonatology team. We will not aspirate. We will not drink. Okay. Any questions, guys? I'm sorry. It's going to take me for 5-10 minutes more. Okay. It's already 10:40. I'm really sorry, but this is a very important question again. What is maternal collapse? Acute event involving either a cardiorespiratory or a neurological compromise in a pregnant or postpartum woman, resulting in reduced or absent consciousness and requiring immediate medical intervention to prevent maternal or fetal death. Okay, maternal collapse. Important causes of maternal collapse, I'll just skip this because the maternal collapse has been beautifully given here. This is a table for maternal collapse. This is also good, very good table. In fact, this is the table which you will remember. But what they want to hear is something like this. Yeah. 4H and 4T. Hypoxia, hypovolemia, hypothermia, hyperkalemia. These are the 4H. And tone, where is that? Oh, sorry, tamponade, toxin, tension, thromboembolism. These are the 4 T's for maternal collapse. Thromboembolism, tension pneumothorax, toxicity, and tamponade. Okay. Hypoxia, hypovolemia, hypothermia, hyperkalemia, these. Okay. Now, question was briefly, this is the last question. Okay. Briefly outline the management of maternal collapse at 34 weeks of gestation. Very beautifully made answer. This is, I'm very proud of this answer. First of all, what you'll do is immediately you'll call for help. Okay, and you'll activate the obstetric emergency protocol. You'll immediately do the risk stratification with the Muse chart. I hope you all know by now what Muse chart is. Okay, obstetric scoring, right? Emergency scoring. So you have to do immediate obstetric scoring and activate the obstetric emergency protocol. Correct? Positioning the patient in a left lateral tilt position. So the moment there is a maternal collapse, you immediately call for help. You do the emergency protocol, obstetric protocol activation, and you position the patient left lateral tilt to give 15 to 30 degree. Why? Because you want to immediately relieve the aortocaval compression. Then you start with the ABC, that is airway, breathing, circulation, immediately. Correct? And then you go for identifying what could be the cause. Quickly, put one, scrub nurse for finding out what the cause is. How is the patient doing? Is she looking hypoxic? What is her oxygen? What is her blood pressure? What is her temperature? What is her, level of sugar and potassium? Is there a possibility of a thromboembolic clot? Is there a possibility of tension pneumothorax? Is there sepsis? Is there any, cardiac arrest, tamponade? And if nothing is working out, you have to do a perimortem cesarean section, which is to be done within 4 minutes of activating the emergency protocol the moment the patient has collapsed. Immediately in 4 minutes, you have to do a cesarean section. And this is not to save the baby, this is to save the mother. Delivery within 5 minutes of maternal collapse and continued resuscitative efforts. If you're giving CPR, you will not stop. If you're giving oxygen, you will not stop. If you're giving any drugs, from pumping of the drugs, you will not stop. You will wait for the defibrillator. You'll assess the rhythm and you will give her a defibrillator shock if it's a shockable rhythm. That means VFib or VTAC. Correct? Maternal monitoring, you have to continuously do the monitoring of the vital signs, oxygen or urine output, and ICU support if needed. Fetal assessment, we are compromising the fetus when it's coming to maternal collapse. Remember always that, okay? The fetus is compromised. And with this, we finish with the maternal collapse and also the question and answers. I'm sorry for extending it to 10:40, is it? Sorry, yeah. So I'm ready for any questions if you have any. Otherwise, we can call it a day, guys.